Good afternoon. Welcome to Medical Grand Rounds, to our folks here and our folks online. I'm Bob Wachter, Chair of the Department of Medicine. This is a topic we focused on a fair amount over the past year, but it deserves it. It is there really has been a revolution in the way we think about treating cancer, and it's made it extraordinarily difficult for folks like me to even try to keep up with what's going on, because there are so many new developments, and they really are exciting, and they're changing the prognosis for a lot of our patients with cancer. And I'm thrilled that we are really a national and international leader in the area, in part because of the two speakers today. The topic is an immunotherapy renaissance in hepatobiliary cancers. And our two speakers are Katie Kelley, who's a GI oncologist. She's a professor in our division of hematology oncology, and she's just taken on the role of associate chief of the division, focusing on clinical research. Her specialty is the care of patients with hepatobiliary cancers, and her research is in clinical trials for new treatments and combination therapies for these cancers, including, as you hear about today, immunotherapy approaches. Katie is nationally known for her work. She's won numerous awards, including the American Society of Clinical Oncology's Young Investigator Award and the National Cancer Institute's Clinical Investigator Team Leadership Award. She graduated from Harvard undergrad, UCLA School of Medicine, resident there, chief resident there, and then we were lucky enough to recruit her here for fellowship in Hem/Onc, and she has stayed on. So thrilled to have her. And she will be joined by Bridget Keenan. Bridget's a physician scientist who focuses on translational cancer research and medical oncology. Her clinical focus is on cancer immunotherapy, where she leads a number of trials of patients with solid organs being treated with these new therapies. She has a particular focus on GI cancer in that area. Bridget received her undergraduate degree from Loyola University of Maryland. Her MD, PhD, and her PhD was in immunology from Hopkins. And then we were lucky enough to recruit her here for her residency, and stayed on for her Hem/Onc fellowship, and joined our faculty a few years ago. Both fantastic contributors to our department and our cancer enterprise, and look forward to hearing the talk. I think both are going to come up.
So thanks so much, Bob, for the kind introduction. Dr. Keenan and I are going to tag team today, but I'll lead off. So the title of our talk, as Bob alluded to, is an immunotherapy renaissance in hepatobiliary cancers. And again, we just want to thank Bob and the Grand Rounds Committee for the invitation to speak today, since there's a lot of very interesting work going on in liver cancers these days. So here are my disclosures, largely related to the conduct and development of clinical trials conducted here at UCSF, and Dr. Keenan's as well. So our objectives are to expand our awareness of the clinical challenges and unique immunobiology in primary liver cancers, identify the recent clinical advances in immunotherapy for hepatobiliary cancers, and share what we think is a great example of team science and longitudinal mentoring in bedside to bench translational research. So we'll both start with a bit about ourselves, and me first. So this timeline demonstrates my path from fellowship to faculty. I, as Bob alluded to, received my MD and performed residency and chief residency at UCLA. Subsequently, I came here to UCSF for hematology oncology fellowship between around 2006 to 2010, where by serendipity, I joined the GI oncology group under the mentorship of Dr. Alan Vanook, who introduced me to the enormous unmet need, but also the fascinating biology of hepatocellular carcinoma and biliary tract cancers. This is a snapshot of my first big paper that Alan was so kind to co-write with me in the Journal of Clinical Oncology about the only treatment we had for liver cancer at the time, a multikinase inhibitor called sorafenib, whose outcomes, though a huge advance in the field at the time, were rather modest at best. Dr. Emily Bergsland was also our program director and was an enormous benefit in teaching me how to run clinical trials. I joined faculty in 2010 and have since become a clinical trialist in hepatobiliary cancers. Here's a snapshot of a paper I'm particularly proud about, which I'll show more about in some of the ensuing slides. And I've had the great privilege to work with collaborators and colleagues throughout the rich breadth of UCSF's experience in liver cancer, from hepatologists as well as lab-based scientists such as Dr. Keenan and my GI oncology partner, Dr. John Gordon. Dr. Keenan.
Thank you. We're so excited to be here today and thought that it would be helpful to tell you about how we came to work together on this topic. So my background starts a little bit differently. I initially became interested in this topic by my PhD in immunology, where I got a chance to do a deep dive into another GI cancer, pancreatic cancer, and study vaccines targeting KRAS. This was at Hopkins under the direction of Liz Jaffe, who was a fantastic mentor and contributed to my lifelong love of tumor immunology and immunotherapy. I then came here as a resident and joined the fellowship class after that. And I was lucky enough to meet two fantastic mentors, Dr. Kelley here and also Dr. Larry Fong. And during my postdoc portion of the oncology fellowship, I worked in Larry Fong's lab researching the mechanisms of response and resistance to immunotherapy in gastrointestinal cancers, which you'll hear more about today. And through a partnership with Dr. Kelley, was able to look at some of the samples from her clinical trials and other collections of liver cancer specimens. And this eventually propelled me into a faculty career here where I work in the Cancer Immunotherapy Clinic. I treat patients on early phase immunotherapy, and I also still study these samples in the lab.
So the liver is a very complicated organ, and so we always find it helpful to review some background on hepatobiliary cancers before we launch into clinical research and translational research. So I think all of us in internal medicine are well aware that the liver has this complex anatomy, and tumors within the liver take various forms and shapes and flavors biologically. These include hepatocellular carcinoma in the organ of the liver itself, HCC, other biliary tract cancers from the bile ducts within the liver and the gallbladder, including GBC for gallbladder cancer, cholangiocarcinoma, referring to the tumors through the biliary tract as a whole, or CCA. We use the acronym ICC for intrahepatic cholangiocarcinoma. Perihilar cholangiocarcinoma is another important biologically distinct subgroup. And then there's distal cholangiocarcinoma arising outside the liver and reaching down to the pancreatic duct junction with the duodenum. So all of this is a complicated alphabet soup. So we wanted to define the acronyms, but actually, as it turns out, ABC also is used as an acronym for advanced biliary cancer. So this little icon is a bit of a twofer. So beyond the anatomic complexity, though, biliary tract and HCCs have very heterogeneous etiology, which impacts on their biology, making them very varied, both anatomically as well as biologically, as well as microenvironment wise. So risk factors include viral hepatitis B and C, alcohol, steatosis or fatty liver, fluke infections predominantly for cholangiocarcinomas, hereditary factors predominantly for cholangiocarcinomas, as well as autoimmunity. And again, arising from this complexity and heterogeneity, we see significant heterogeneity on an immune level and on a tumor biology level. And another important challenge to be aware of with liver cancers is they have highly prevalent comorbidities that impact our care and impact our research abilities, including underlying liver disease such as cirrhosis, infections or obstruction, which can cause cholangitis, and very importantly, health disparity. We see that rates of biliary and HCC cancers are much higher in disparity populations, especially in the United States. So speaking to the epidemiology of hepatobiliary cancers, these are overall tumor types on the rise. You can see on the right the SEER data from 2024 showing in the light green the rising incidence of HCC and ICC. Again, that's the acronym for intrahepatic cholangiocarcinoma, which is gradually increasing, a little bit of a plateau right now. Death rate in dark green is increasing. Prognosis is poor with all-comer 5-year survival about 20%. That number is much lower for the proportion of patients that have advanced metastatic or locally advanced disease, which is in the 5 to 10% range. So very poor prognosis cancers still. They are currently, the HCC and ICC combined are the third leading cause of cancer death worldwide. And based on SEER data, they are projected to become the third most common cause of cancer death in the United States by 2040. So again, hugely impactful and important cancers with a poor prognosis. Thanks to antiviral therapy for Hep B and Hep C, the cases due to viral hepatitis are declining, and that's why we see this incident epidemiologic plateau right now. But the big specter on the horizon is steatotic liver disease. That's the new acronym for NAFLD. So metabolic associated steatotic liver disease is the new acronym referring to fatty liver related liver disease per the WHO and AASLD. It is now the fastest rising cause of both HCC and ICC. Here's a paper from Journal of Hepatology a couple years back, which just shows the incidence and of decompensated liver cirrhosis, liver-related death, and HCC due to fatty liver, which you can see throughout regions of the world is gradually increasing and projected to increase further, HCC being this bottom gray line, but again, all of these trend lines are increasing. So HCC and cholangiocarcinoma both arise in the liver and have overlapping but distinct biology, and this is where I'd like to hand it off to Dr. Keenan to give a little more detail.
So we already talked about some of the complexities in the anatomy about where and how these cancers arise, but there's beyond that additional histologic, risk factor, and mutational differences as well as overlap in these cancer types. And this slide captures some of that, but can't even completely capture it because they also left off gallbladder carcinoma and extrahepatic cholangiocarcinoma. In HCC, some of these risk factors like viral hepatitis and mast cell are more common, but they can also contribute to the development of cholangiocarcinoma as well. And in fact, just to add to the complexity, there's also an overlap diagnosis of combined HCC cholangiocarcinoma, which is a small proportion of these primary liver cancers that share features of both. They are driven by different mutations, and cholangiocarcinoma in particular has more driver association, more mutations that are associated with it that can be targeted. There are now FDA-approved therapies that are across cancer types, not only within cholangiocarcinoma, to target some of these driver mutations. That's not going to be the focus today as we're talking about immunotherapy, but I wanted to point out how this landscape has changed, really made big strides in the past couple of years with targeted therapies for this whole list here. I'm not going to read through all of those mutations and talk about the drugs that can target them, but I will point out that there is a small subset of cancer that express or have a high tumor mutational burden or have microsatellite instability. And across the board, regardless of the cancer of origin, these patients would be eligible for immune checkpoint inhibitors. But again, a small proportion of cholangiocarcinoma or HCC. Adding to that complexity, there is also a different immune microenvironment, even within cholangiocarcinoma based on the site. And so this is one study that was published in Hepatology showing that for ICC or ECCA, the intrahepatic versus extrahepatic cholangiocarcinomas, there's some things that are similar between the two. So for example, they both have high CD4 T cells that are infiltrating, but in the intrahepatic cholangiocarcinomas, they are more likely to have a myeloid cell infiltrate like dendritic cells and macrophages, whereas NKT cells and B cells predominate within the extrahepatic. So there's a different immune milieu that can lead to differences in how these tumors develop and how they progress. Again, adding to the complexity in HCC, there are all of these risk factors that are often associated with the development of these tumors, such as viral hepatitis and mast cell, as Katie talked about. And so these can lead to increasing degrees of fibrosis and cirrhosis, eventually culminating in HCC. And under normal conditions, the liver is tolerant, but when there's chronic antigen stimulation, there can also be immune dysregulation resulting from that. And I won't go into all of these cell types we diagrammed out in our review that Dr. Kelley, Dr. Fong, and I published at the beginning of our work together, but I will just summarize by saying, while there are some challenges related to the microenvironment of HCC, these also may be opportunities to get immune therapies that work. For example, checkpoint inhibitors that can reinvigorate exhausted T cells.
So just to go back to our historical timeline, on my timeline when I started fellowship and started working with Dr. Vanook, sorafenib was the only treatment option with level 1 evidence in HCC, and that remained the case until 2017, despite it being one of the largest cancer types worldwide. And likewise, there were no actual FDA-approved therapies for biliary tract cancers until around 2020. And we just used chemo that we use for pancreas cancer because there was no trial and no data to guide us. And evidencing this, there was no specific systemic therapy guideline from the NCCN for either of these tumor types until 2018. And again, median survival in this era was less than a year. But thanks to immunotherapy, we have now seen a huge change in the treatment landscape. With immune checkpoint inhibition, again, another acronym ICI that we'll use, we actually see durable responses in about 15% of HCC patients when used by itself as monotherapy. And here's an example. This is one of Dr. John Gordon's patients who had a large infiltrative right lobe tumor that after 6 months on nivolumab just disappeared, and that patient developed a complete response. Those dramatic responses that we saw in the clinic that were so durable and meaningful led to an accelerated FDA approval for nivolumab back in 2017 and prompted the launch of a phase 3 confirmatory trial called Checkmate 459, which you can see here with the nivolumab survival curve in blue and the sorafenib, that was the control at the time, survival curve in orange. And while we see a nice separation and the blue curve looks better, that's where I'd want to be as a patient. I'd want to be on that blue curve. Unfortunately, this trial did not meet statistical significance. It wasn't a big enough change. And so it's a reminder that unlike horseshoes and hand grenades, regulatory trials and FDA registration is close is not good enough. So this approval was rescinded at the time. And that signal of dramatic response in a subset, but not quite enough as monotherapy, is what brought us to the era of combinations. So we saw these drugs that have enormous potential, but again, not quite enough for most patients. And so the question became to find what combinations are better together, so to speak. And so the two forefront strategies have been immune checkpoint inhibitors combined with anti-angiogenic agents. Can't really see this cartoon, but the general idea is that targeting VEGF helps reduce or inhibit the immune suppressive elements of the microenvironment and promote some of the immune responsive elements of the microenvironment, thereby letting the checkpoint inhibitor work better. And the other forefront strategy is combining two different complementary checkpoint inhibitors, like a CTLA-4 inhibitor plus a PD-1 or PD-L1 inhibitor, to inhibit two different negative signals and thus let your immune system respond better. And then there are a whole host of other combinations, still ongoing research, including other IO immunomodulatory agents targeting the microenvironment and local regional combinations, local regional therapies such as TACE or TARE. So the first big advance was the combination of atezolizumab, a PD-L1 inhibitor, plus bevacizumab, the anti-VEGF monoclonal antibody in the IMbrave 150 trial. And here we see in the dark blue line, the combination atezo-bev survival curve compared to the control sorafenib. And basically this trial set a new benchmark for efficacy with survival in the combination arm of 19 months versus 13 months for sorafenib. And the secondary or the co-primary endpoint of PFS was likewise improved. And these were highly statistically significant. And in the clinic, we saw about a third of patients had deep and durable responses, so twice as much as monotherapy, including complete responses, meaning remissions, in about 8% of patients. Now, I have to note that this trial did show very acceptable safety in the study population, but all patients required endoscopy because of the risk of variceal bleeding, and any patients with high-risk varices or any other high-risk cardiovascular disease or risk for bleeding were excluded because BEV can incur bleeding risk. So it's an important consideration, particularly as we think about the MASLD population with diabetes and hypertension and other covariates that go with fatty liver. But so this drug combination of atezo-bev was FDA approved in 2020 and remains our forefront treatment option today. Turning to the next strategy of immune checkpoint inhibitor combinations, here I'm showing some data that I'm from that paper I showed on my first timeline, the paper I'm particularly proud of. This was a phase 2 study that looked at 4 different ways of giving checkpoint inhibitors in a large randomized international phase 2 trial looking at a CTLA-4 inhibitor tremelimumab with a PD-L1 inhibitor durvalumab in various different sequences and combinations. And what we found is that the single dose of the CTLA-4 inhibitor tremelimumab, just given once, plus monthly durvalumab, had the highest response rate, and that those responses were durable. The median duration of response was a whole 2 years, meaning half the responses were even ongoing. We still have patients who are having response even now the trial's long done. And that arm also had the longest survival. And intriguingly, from a biomarker perspective, we saw that combination arm with these little purple dots here, it elicited the highest proportion of a particularly activated CD8 T cell population in the peripheral blood. So we have a biomarker signal, response rate signal, a survival signal, all showing that this combination was doing something. And so that launched a phase 3 trial called Himalaya, which looked at some of those same combinations versus the then control at the time of sorafenib. And what it showed is that in the dark blue curve, the single dose tremelimumab plus the regular interval monthly durvalumab, which has since been given a new acronym, STRIDE, that dark blue arm curve here had a significantly improved overall survival compared to standard sorafenib. And most importantly, when we're talking to a patient in the clinic, that benefit is durable. Those patients continue to do well if they have a response and continue and had an initial benefit. We see actually that the curve almost flattens. And in fact, there's going to be 5-year data presented showing that this curve is pretty flat coming up at GI ESMO in June in Europe. So this regimen was also FDA approved. Here's a quick show and tell of an actual patient on that trial from our clinic, a man who had Hep C treated with direct-acting antiviral therapy, metastatic disease in multiple lymph nodes, plus multifocal liver disease. Here's arterial enhancement adjacent to an old TACE site in the liver, which washed out on portal venous imaging. That's the pathognomonic radiographic finding of HCC. So he had metastatic disease. He also had big gastric varices that were too high risk for BEV. So we couldn't use atezo-bev. He got randomized to the single-dose tremelimumab plus durvalumab STRIDE arm on the trial at UCSF and had an immediate AFP response. And within 2 months had a partial response radiographically, by 4 months a complete response. And as of just this past month or two, he's still in complete response 5 years later off treatment. So again, that's a subset of patients, but that roughly 25% of patients who respond, they stay responding. So shifting gears a bit to biliary tract cancers, as Dr. Keenan alluded to earlier, the immune microenvironment in biliary cancer is different than in HCC, and that manifests in the clinic with a lower response rate, less durable responses to immune checkpoint inhibitors. And we see with monotherapy, instead of that really dramatic 15% of patients where you see relatively often if you see a lot of patients, we very rarely see immune checkpoint inhibitor responses to monotherapy in biliary tract. This was a large study that showed about a 5% response rate, which I think is pretty accurate in the real world. This has been reproduced in multiple other small studies. But there was good safety, and it really begs the question, same as in HCC, could we do better by combining this with a different strategy? So in fact, chemotherapy has now been studied in combination with immune checkpoint inhibitors in 2 randomized phase 3 international trials. One's called TOPAZ-1 with durvalumab plus standard gemcitabine cisplatin chemo, and the other trial is called KEYNOTE-966 with the same chemo drugs, gemcitabine cisplatin, with a different checkpoint inhibitor, pembrolizumab. Both showed that the top curve, which is the immune checkpoint inhibitor arm, differentiates and has a statistically significant improvement in survival over the chemo alone, the bottom curve. But I think we would all agree that these are rather modest. We don't see quite the big delta and quite the flattening that we saw with HCC across the board when we look at multiple data sets. So it is an improvement, and it is much needed, and a subset of patients do benefit. So, and these trials were frankly positive. And so the FDA did approve both of these regimens in 22 and 2023, but we still need new strategies. So here's a current summary before I transition over to Dr. Keenan's translational science research. For HCC, where we are in first-line HCC right now is that the combinations of atezo-bev from the IMbrave 150 trial, and then durva-tremi, the 2 immune checkpoint inhibitors from the Himalaya trial, both improved survival and have been FDA approved as first-line options that we have in the clinic, and have definitely advanced the field. And there are other combinations on the horizon. These combinations are also being studied in earlier stages of disease, like adjuvant after surgery, or in combination with local regional therapy. So very exciting times. But we still don't have a lot of treatments when patients progress, and the survival is still less than 2 years. So still a lot of work to go. And in biliary tract cancers, we now have FDA approvals for the chemo plus immune checkpoint inhibitor combination that has become our de facto standard of care. But the median survival is still only around 12 to 13 months for the average patient. And we have an unmet need in the first line as well as beyond. And I feel like we're sort of at the first landing on the Dipsy trail, where we've come a bit of a way, but we still have a valiant effort ahead for a very worthy cause. So how can we make progress and get further up that trail? And so, of course, we're always looking for new combinations and novel agents. That's what I do in clinical trials. But we're also, this is critical to be guided by translational research into mechanisms of primary and acquired resistance and identify the biomarkers affecting these resistance mechanisms. And so one of the projects I've also been working on for many years now is the UCSF Hepatobiliary Tissue Bank and Registry. I initiated this bank in 2012 with Dr. Vinook's guidance and support, and the very generous philanthropic support from a patient's family who had passed away. And it's been funded by various grants and gifts over the years. And since initiation in 2012, we've collected over 600 We consented over 600 patients for this bank, and from most of those patients, we collected blood sample, permission to access their archival tumor from biopsies or surgeries, and if they're having a surgery, if we catch them before they have a surgery, we also get fresh tissue. We keep all the data, we curate all the data in terms of stage and diagnosis details, treatment response, and survival using our institutional enterprise ENCORE database, and samples are stored in the BSPL, formerly known as BIOS. So over the years, we've had many collaborations, and I'm incredibly proud of this map to show all the different colleagues across the country and across the world, in fact, with shared data or samples or both. We have lots of great collaborations going on at UCSF, including Dr. John Gordon, Dr. Andre Goga, Dr. Mike Lee, and others. But I'd like to turn over to Dr. Keenan now to share what she's been doing with HBTBR samples to really make progress on take that next step forward.
Okay, so before I transition to some of the lab-based research that I've been working on, I'll set the stage by talking about one of the trials where these samples came from. And this was an investigator-initiated trial that Dr. Kelley designed several years before I joined the fellowship program, and I was able to come in at a point where we had already collected many of these samples from patients on the trial. And this is before the era of chemo and immunotherapy combination being approved in biliary tract cancers, but we knew at that point in time that single agent checkpoint inhibitors had very limited efficacy in this patient population. So the idea here was to combine pembrolizumab, a checkpoint inhibitor, with GM-CSF, which is a cytokine that can, among other things, activate antigen-presenting cells. So taking immature dendritic cells and making them into better antigen presenters. The idea would be to combine this with the pembrolizumab to augment the T cell responses that pembrolizumab aims to reinvigorate. This was a phase 2 trial with patients who had already been pre-treated with chemotherapy and had advanced biliary cancers. And while this didn't achieve its primary endpoint in terms of the target response rate, there were a number of patients that had clinical benefit in this small study. And so about 5 of those 42 had confirmed partial responses. But what was really intriguing was that there were a number of patients that had stable disease for 6 months or longer, which in this devastating disease really would be a win. So about a quarter of those patients total either achieved that progression-free survival for 6 months or an objective tumor response. And those were the patients we set about the study to understand why there were responses, whereas there was resistance more often than not. And there was also a trend towards a longer progression-free survival with viral etiology. And I'll come back to that when I talk more about our next steps in hepatocellular carcinoma, where we have many patients who have been also infected with viral hepatitis. So we took these samples from patients that were treated on the trial in the lab, and we were able not only to sample their blood at baseline, but at multiple time points while they were receiving the checkpoint inhibitor and GM-CSF. I'm going to focus today on the patients that had just received the checkpoint inhibitor alone up front. For simplicity's sake, there's a lot of data here in this paper and another paper that Dr. Kelley and I are working on about these different cohorts. And what we did in the lab was we used these high dimensional techniques that at the time where I was starting my fellowship were really cutting edge and now have been more largely adopted by others. And what we did here was a single cell transcriptomics. So we get the mRNA from each cell on a single cell basis. But we also combine this with single cell proteomics, what we called CiteSeq, where there's about 100 antibody panel that we can use to tag surface proteins on these cells. And I'll come back to how we were able to use that for further study. We sequenced over 200,000 cells from the blood of patients on this trial, as well as healthy donors. And what we set about to analyze in the lab was looking at their circulating immune system. My hypothesis up front was that the pembrolizumab would have an effect on these patients' T cells. However, the interesting thing that we saw was that the most predominant effect we were seeing was that this was in the monocyte compartment. And so specifically, we were looking at CD14 positive or classical monocytes. And what we found was a very binary result, whereas the patients where they had clinical benefit, so the stable disease for 6 months or longer, or partial responses, had a high proportion after the start of therapy of what we called CD14 APC. This was a subgroup of classical monocytes that had high gene expression for antigen processing and presentation, which would be advantageous in the setting of an anti-tumor immune response. Whereas patients that didn't have any clinical benefit, they had a very high proportion of these other classical monocytes that had a high expression of immunosuppressive chemokines and cytokines and molecules involved in chemotaxis. So for that reason, we labeled these cells CTX for chemotaxis. When I did a gene expression looking at these two cell types in particular, because there was a very binary response here between responders and non-responders, I saw that immunosuppressive cytokines like IL-8 and IL-1 were highly expressed, as well as a number of other molecules. And here's where we use the site-seq panel. We were able to look for molecules that were not only expressed at the gene level, but the protein level. And two of those were CD29 or integrin beta 1 and TIM3. And the reason that was advantageous is that we were then able to make a flow cytometry panel to tag these cells and isolate them so that we could do in vitro co-culture. And we validated that with the flow cytometry panel that we found a higher proportion of these CTX cells using those markers in the same population that we did the single cell RNA-seq on and a validation population. We then co-cultured them with healthy donor T cells. That's what I'm showing here on the bottom. And we also used as control healthy donor monocytes from either the same patient or a different patient or T cells alone. And what we found was that these CTX monocytes could induce a number of different phenotypes in the T cells. First, they suppress T cell T cell proliferation, both CD4 and CD8 T cells. They also induced a protein called SOX3, which is a suppressor of cytokine secretion. And indeed, we found that when we looked at cytokines like interferon gamma and TNF alpha, as well as IL-2, that when we co-culture with CTX, these cells not only express, the T cells not only express a higher amount of SOX3, they also had lower amounts of cytokine. And these are cytokines that we would want in the context of an anti-tumor immune response. And SOX3 has been shown in other publications to be a mediator of immune paralysis. So this is what we propose as the mechanism of how these cells could drive resistance in the setting of checkpoint inhibitor therapy. So it's a lot of information from one slide of data. There's plenty more in the paper that we published together in Cell Reports in 2022. And this is a graphical abstract summarizing that within patients who did have a response, they had a higher number of these antigen processing and presentation, classical monocytes, whereas patients that didn't have any clinical benefit from the treatment with anti-PD-1 had a high proportion of the CT14, CTX cells that we then showed could induce SOX3 and induce immune paralysis. This was interesting, and we wanted to take it forward in other cancer types. We did within the paper, we looked at publicly available data sets like the TCGA and validated the signature was prognostic of both outcomes on immunotherapy as well as overall survival. But we really also wanted to tie this back to our interest in HCC. And so before I go into the data about that from the lab, I want to bring it back to some of the clinical questions that we had. So especially in HCC, more so than in biliary tract cancer, patients have underlying liver dysfunction. And this goes back to that review that we had published several years before, thinking about how the context of fibrosis, cirrhosis, hepatitis would all contribute to liver dysfunction. And with worsening liver dysfunction, there might be a decreased response to checkpoint inhibitors. And sure enough, that has been seen by Dr. Kelley and others in this paper, including in this paper we published in Cancer, that the Child-Pugh score, which is used to measure liver dysfunction, we see that with Child-Pugh B, or worse liver function, that there are increased comorbidities and a worse response to checkpoint inhibition. However, we also showed that it's safe to treat these patients with checkpoint inhibitors. That's important because they make up a large proportion of our real-world population that wasn't in trials. We also thought about liver disease etiology, and I won't go into all the literature on that, but I will just say that it has been somewhat controversial because there's been some papers that showed that having a non-viral or a mast-celled liver disease etiology response that correlates with T cell dysfunction and worse response to checkpoint inhibitors, whereas there are other papers that did a meta-analysis showing that there's really no effect about whether there's viral or non-viral hepatitis. Still a question in the field about how that affects the response to therapy. Because of the cohort, to answer some of those questions and look further into them at a deeper level with the single we applied to biliary tract cancer. And in terms of the cohorts, we've been able to go back and use the HBTBR as well as an investigator-initiated trial that Dr. Kelley ran in the GI Oncology Clinic using one of these combinations of a tyrosine kinase inhibitor, sorafenib, along with nivolumab or anti-PD-1. We collected, again, PBMCs from baseline as well as on treatment from that trial. And lastly, we've collaborated with Dr. Jennifer Lai on her frailty cohort as well as her colleague Lee. And Dr. Lai and Dr. Lee have been very generous in sharing their samples with us from that cohort. These are patients presenting for a liver transplant evaluation, and a subset of them have the samples from that subset. There are a number of questions that I talked about on the previous slide that we want to answer in terms of liver disease stage and hepatitis etiology, but also we can look at the effect of these treatments on the circulating immune system. This work is ongoing. However, I'll show a little bit of preliminary data so far. Similarly to the biliary tract cancer project, we applied some of these techniques, including site-seq, and we've also applied T-cell receptor sequencing that can be done on the single cell level as well. And here you see a UMAP plot. Many may be familiar at looking at these, but if not, every single dot on here is a single cell, and they cluster according to their gene expression, so similar cell types cluster together. We applied markers for myeloid cells such as CD14 and CD68, and we can pull out the myeloid cells in this map and also apply the signature of the CD14 CTX suppressive monocytes. What we see is that within the patients that have the non-viral etiology, there seems to be an increased proportion of these cells. However, there may be more than one population of monocytes that has a gene signature that's suppressive, which is a bit different than what we saw in biliary tract cancer, and the work is ongoing to understand this. I'm now going to bring it back to the clinic after giving a little bit about those different projects that we're working on in the lab. And so far, we've talked about different steps in this cancer immunity cycle that can be targeted in the clinic. One of them was the use of GM-CSF to increase antigen presentation. We've also talked about checkpoint inhibitors that are used to try to overcome T-cell exhaustion and reinvigorate T-cell responses. And one thing we haven't talked about yet is recognition of cancer antigens by T-cells. In cases where that's deficient, or maybe it's a numbers game where there's not enough of these tumor antigen-specific T-cells, we can use engineered immune cells or cell therapy. And many of you may have heard of this, particularly in the context of CAR T cells. In fact, there are many other ways to do this with engineered immune cells, including TCR therapies that use the endogenous T cell receptor. However, in that case, these are MHC restricted, whereas CAR T cells don't have that limitation. Generally, these are derived from a patient's own blood. In some cases, they can also be obtained from a healthy donor. So the first step is to undergo apheresis, where white blood cells are removed from a patient's body and then sent to a cell manufacturing lab. At that point, they're activated, expanded, and we put in a receptor, either the CAR or the TCR, and then they undergo additional processing and manufacturing steps until they're ready to be infused back into a patient. In reality, this could actually take a number of months to find the right patients, to identify them, to screen them for a trial, to have them undergo apheresis and manufacturing. And so for patients with advanced cancer, and especially those with comorbidities of liver disease, this can be very challenging. However, as we've seen from hematologic malignancies, these therapies also have a lot of hope. There's also side effects that can be significant from these, such as cytokine release syndrome and neurotoxicity, and some of you may have encountered these on the wards. There's currently a number of trials that are looking at different targets for HCC in the clinic. And to talk more about one of these, I'll turn it back to Dr. Kelley.
So GPC3 stands for glypican-3. And it's a heparin sulfate proteoglycan that's overexpressed in a subset of HCC tumors and has a poor prognosis correlation, and may play a role in growth and metastasis and development, but it's absent in healthy tissues. So that makes it a good candidate for cell therapy. And so in collaboration with AstraZeneca, learning about cell therapy that they had been working on, specifically targeting GPC3, we developed a collaboration using samples from the HBTBR of HCC tumors and non-tumor liver. And our analyses showed that there was a pretty high expression rate in overall in HCC in our samples from UCSF. They trended higher in metastatic lesions versus primary lesions, and that there was some difference according to etiology and race and ethnicity, with much higher rates in Asian and Hep B positive patients, up to 100% for both Asian and Hep B in a small cohort, versus only about 50% for MASLD or non-viral HCC or Caucasian. So very important details to know in planning a biomarker-driven trial. Who is your population? How do you test for it? And we also can see that the normal liver on the immunohistochemistry samples from the normal liver, that this truly was not expressed in any of the samples we provided, and that the immunohistochemistry marker using Ventana for the future clinical trial, but a proprietary one here, is quite prominent in terms of the extent of GPC3 expression. So a nice binary marker with respect to what we can use in the clinic. So I wanted to show this not only because I'm enthusiastic about GPC3 as a potential tumor antigen for HCC in the future in the clinic, but also because it's really meeting our mission of the HBTBR to be able to take samples that we obtained in our patients in our clinic over the years that we have manually curated for their viral status, their survival status, their etiology, paired it with primary and metastasis samples, and in some cases, actually plasma samples, and then be able to build a trial biomarker plan based on these data. And so that's the entire point of what we're trying to do. And so this is something that we're really excited about. The other point of HBTBR and what we're excited about with this particular collaboration is it let us get in on the ground floor for a really exciting clinical trial, and led UCSF to be selected as one of the initial sites and the lead site for this trial. And so the PI for this trial at UCSF is Dr. Keenan, and so she'll tell you more about it.
As background for this trial, there was actually a previous and in fact ongoing trial that was run with the same construct. So this is a GPC3 targeted CAR. And the other thing that they've done is put in a TGF-beta receptor 2 dominant negative as part of the construct. And the way that that works is essentially like a sink for the TGF-beta. We know that this is a player in HCC, and it could be suppressive to the CAR T cells and the endogenous immune response. So the idea is that this is a way of armoring the CAR. And there are a number of these strategies that are in the clinic to make these CAR T cells more efficacious. This early phase trial, CCAR 031, was started and being run still in China. And at the time of the cutoff for the AACR meeting last year, where this data was presented, there had been 6 patients so far that had been treated. At the time, 4 out of 6 of them had unconfirmed partial responses. And you can see here from the tumor shrinkage plot that at least 3 out of those 4 had pretty significant tumor shrinkage, and that these responses were ongoing for, out to about 6 months. And again, this data was cut off at some point a while ago, but that was already very encouraging. And the adverse effects that were seen were cytokine release syndrome, which is not surprising for CAR T cell program, but this was only grade 1 or 2. And so this was very much in line with other CAR T cell what is expected in a CAR T cell program, and no concerning dose limiting toxicities at this time. So based on this early phase data, there is now a larger study that is launched here via AstraZeneca, and this is called the Athena trial. So this is using the same armored GPC3 CAR T cell, and we're able to go up a few, not start at the very low dose level because we have data from this other study. So we aim to do a phase 1B where we're going through just a few small cohorts in a dose escalation before launching a larger phase 2 trial enrolling up to 50 patients. And this is for patients with advanced HCC that have been treated with at least 1 line or more of prior systemic therapy. They do have to have Child-Pugh-A liver function because, again, I talked about what some of the risks of these therapies might be in somebody with more severe liver dysfunction, and of course, GPC3 positive. The study opened late 2023 across the United States, and our study opened in the past month or 2. We are gearing up to apheresis and treat our first patient in the next 1 to 2 months, which is very exciting. So with that, I want to reflect back on some of the milestones. Dr. Kelley and I had talked about our backgrounds and how we came to this topic of hepatobiliary cancers and immunotherapy from different sides. Myself from immunology and her with having a strong, very long-term interest in hepatobiliary cancers, including the initiation of the hepatobiliary tissue bank and registry. And you can see now how that was started very early on in Dr. Kelley's career, but has fueled many different collaborations, projects, and publications. We've been able to see throughout our mentoring relationship how we've made incremental steps that have added up over time, including several fellowships that I was awarded based on working on the samples from the HBTBR and from her investigator-initiated trials from ASCO and the cholangiocarcinoma Foundation, and leading to several co-publications, both of the paper I talked about today and several others. Most recently, we've been able to open this CAR T-cell trial based on the GPC3 data that UCSF has contributed to. And we've also recently been awarded a Cholangiocarcinoma Foundation Team Science Award for us, others at UCSF and the NIH to work on resistance to the new chemoimmunotherapy regimen that's being given in biliary tract cancer. So we're not done yet. There's a lot more to do. And I'll talk about some of that in the conclusions about what are some of the things still that we need to work on despite this immunotherapy renaissance. So we've talked today about how hepatobiliary cancers are very heterogeneous and complex group of diseases. They have different driver mutations, immune microenvironments, and they also can be related to different underlying liver diseases. And particularly, we wanted to highlight MASLD as this is driving cancer incidence, both in HCC and cholangiocarcinoma. We've also talked today about immunotherapy and how these new immunotherapy combinations with either immunotherapy, 2 different checkpoint inhibitors or a checkpoint inhibitor and anti-VEGF therapies are being used in HCC, and how the combination of chemo and immunotherapy has been used in biliary tract cancer, and some of the novel agents on the horizon, including cell therapy. However, there are still a lot of challenges, including pre-existing and acquired resistance in these diseases, and also safety, particularly these patients that have liver dysfunction. And we wanted to highlight the success in mentoring and collaboration, which is a longitudinal process. And here you can see one of our collaborative discussions actually happened while we were running in the cold in Park City at the Cholangiocarcinoma Foundation conference a few years ago. Of course, this goes beyond Dr. Kelley and I, and there are many that we have to thank for the success of these projects. So namely, Dr. Fong, who's been my other mentor here at UCSF for many years, and the work that I talked about today was done in Larry Fong's lab. There are many in the lab that have helped with that, that I need to give recognition to, as well as other labs here on campus. We also have great colleagues in GI oncology, including a senior mentor to both of us, Dr. Alan Vinook, and our colleagues in UCSF hepatology and the Cancer Immunotherapy program, and in our greater division and department. We have a lot of fantastic coordinators that work on our trials. And of course, we can't forget the patients and caregivers that we take care of. They're at the heart of everything that we do. We've had success in funding so far. Here are some of our funding sources that have really helped drive this work.
And we wanted to close also with an enormous thanks to our extraordinary multidisciplinary team of clinical colleagues here at UCSF. This is a snapshot of a sort of impromptu mini symposium we had together in November. And you can see well-known colleagues from hepatology, interventional radiology, surgery, medical oncology, immunology, and then a lot of our clinical team members, including our nurse practitioners or nurses, all joined together, and we shared recent abstracts and updates since there's so much going on. And more so perhaps than many other diseases in medicine, liver disease in general, liver and biliary tract cancers in specific really are essentially managed with a multidisciplinary team. And we are so lucky here at UCSF to have a compassionate team of providers, as well as a passionate team of providers who are all so committed to working together to make things better for our patients. So thank you also to UCSF for creating this environment.
Thanks. That was terrific and inspiring, and really a wonderful story about translational research and bench-to-bedside, and also about mentorship and the joys of both being a mentee and a mentor. So that was really very nice. You mentioned the multidisciplinary colleagues. Is there any role for all of these there? You see that big liver cancer, you wonder about shrinking it and then resecting it or frying it or doing something. What's the role of other disciplines as it relates to the medical therapies that you guys give?
Well, I'll start on the clinical side. It's actually, we see a lot of intersection between immune response and local therapies that we give. And that's one of the things that Bridget and others are working on understanding is how do treatments that we can give to a liver tumor, how can they make it more immunogenic such that our systemic therapies work better? And there are now some trials ongoing combining TACE, TARE, microwave ablation, and then actually a post-surgery systemic therapies. And so there's still an enormous role. And I think what we're most excited about, I would answer as a clinician, is that we are sometimes seeing such a dramatic responses with our immunotherapies that we are able to actually convert some patients to resectable and curable that didn't used to be.
Great. Anything to add?
Yeah, and I can just comment that in the neoadjuvant space, giving immunotherapy has been shown in some early trials to be effective, like Katie said, to generate some of these complete responses where we actually see the tumor go away. And it's also a fantastic opportunity to learn about how they work, because we can, when we're giving a neoadjuvant therapy, collect a biopsy sample at baseline at the time of diagnosis, and then at the time of surgery if these patients are going on to a surgery. So it's also a great translational opportunity as well.
Maybe I'll ask one more, then we'll open it up. I was struck, first of all, when the antiviral therapies came out, I sort of thought maybe you guys would be out of business. And it turns out not. So it turns out now we have a competing cause of liver damage, which seems to predispose. I can't think of other tumors that seem to be so dependent on antecedent damage of an organ. Maybe that's true in lung cancer and lungs are unhappy from smoking, for example, or I don't know about colon cancer, but does it strike you as different that the liver seems to be that liver cancer seems to come out almost only when there's something that's damaged liver beforehand? And is that different from other tumors? And if so, what do you think is going on?
Yeah, that's a great question. I don't know that we really understand that. And I think that's partially what drew me to this field is there's an opportunity to understand both the normal liver immunobiology, which is so fascinating in itself, the context of the liver where there's either fibrosis or cirrhosis and no cancer, and then the combination of all of those factors. And there certainly are cases we see, especially with cholangiocarcinoma, where somebody doesn't really have any risk factors besides potentially genetic predisposition. And so essentially they have otherwise healthy liver. One of the things that we can do with the HBTBR is actually not only when we get those tissue samples, study the affected liver tissue for the cancer, but also the surrounding tumor. So that's one way we can try to answer some of this to understand what is the context that the tumor develops in.
Yeah, but I'm just thinking about like fibrotic lung disease doesn't seem to predispose to cancer in the same way. I don't. What do you think might be different here? Is there any sense of that?
I would say just one step backwards is there is still a lot of heterogeneity where some of the disease is based on this sort of accumulation of mutations over time from fibrosis and an inexorable process where you get layers of mutations, but some are also directly mutagenic. And so it's like hepatitis B virus can insert into a culprit gene such as TERT promoters and cause terrible cancer with zero fibrosis. And MASLD can do that too, believe it or not. And in cholangiocarcinoma, certain genetic predispositions like BRCA mutations can do that. So back to the heterogeneity, we get a lot of questions in this cancer that need to be answered separately. Back to other tumor types that do this. I mean, there's one of Bridget's great interests, as she's told us about, is what does the immune microenvironment do in terms of cancer surveillance? And so to your point, in the liver, it's possible that the fibrosis removes some of that immune surveillance that would normally be preventing a cancer.
Let's open it up. Yeah, say who you are.
Sam Bromfield, oncology, fantastic.
I think I saw your picture in the fellow picture, right?
Was that?
Yes.
That's funny. Awesome talk. I learned a lot. As you know, in the hospital, I see a lot of people, you mentioned comorbidities. I see a lot of people with CHOP-UC cirrhosis and HCC, and not a lot of them are included in trials and are not eligible for a lot of therapies. So I was just curious, especially of the creative treatments you all talked about, or just anything in the future. Is there anything you're thinking about for patients with CHOP-UC or severe cirrhosis with HCC in terms of eligible treatments?
I think we're still, on the hopeful side, now that we have better treatments and earlier treatments, especially if we move into an intermediate or adjuvant space, perhaps some of the nihilism of HCC screening will be dissipated, and we'll actually be looking for these cancers earlier and get a chance to intervene before things get so dire. I think certainly in doing so, even if someone is child PUC, if we catch a cancer early, there's still a transplant avenue. Immune checkpoint inhibitors, as Bridget mentioned from our series here, as well as several other studies, do have acceptable safety with close monitoring. And of course, it's a high-risk population, but there are some immunotherapies that can be given in very carefully selected patients, but it's clearly an ongoing need area. And there's some patients we just don't have treatments for.
And in the patients that you said, we don't do this because we worry about varices and bleeding, is it the therapy that can create or exacerbate varices, or it's just something that gets in the way of your bleeding and clotting?
In the first line setting, we have two choices: a choice that includes bevacizumab, the anti-angiogenic, and a dual immune checkpoint inhibitor choice. In patients that have bleeding risk, we avoid the anti-angiogenic because that is what causes the bleeding or precipitates bleeding in a high-risk substrate or clotting.
Is it just an anticoagulant effect, or it's actually doing something to make varices worse?
Anti-VEGF, not the varices, but the bleeding. Actually, it can increase pressure as well, portal and systemic hypertension, but more specifically, it just promotes bleeding risk through aberrant changes in the vasculature.
I'm actually one of the coordinators for one of your studies for target HCC. So I just really, I'm a GI liver CRC. So I had a couple questions.
Right.
The screening process for HCC is currently for mast cell patients and HPV positive patients, the ultrasound or CT MRI every 6 months. But I'm sure you know that the ultrasound can be pretty limiting in people with MASLD or MASH. So we're working on a new trial with AFPL3 and DCP as biomarkers for the Gallup score that was recently approved as a FDA. So I'm wondering, what are your thoughts on that? And are there any other alternative screening processes besides imaging that we can look into?
Yeah, I think Dr. Mehta's work and your team's work and the Gallup score, UCSF and lots of other sites have helped validate that the Gallup score is an early detection approach in high-risk patients. We don't yet have a lot of data how to use those biomarkers in our advanced disease populations, but certainly the hope is that using that score more often and making sure that primary care communities know about it and that we identify MASLD patients to do that screening in, because right now we don't always know who has MASLD, but hopefully that will help us detect people earlier.
Right. I think we have one for.
Yeah, there's about 60 people watching online. They have a couple of questions. One is, what accounts for the rise of GI malignancies in young people these days? And the second question is immunotherapy better for primary liver tumors than for metastatic tumors, and why?
I can do my best to answer those. So you're right that there is a rise in GI malignancies in younger patients. And I think the main area that we've thought about this isn't so much in HCC and cholangio, although Dr. Kelley can comment on what she's seeing in the clinic, but in colorectal cancer. And unfortunately, I don't think that we really understand that whether this is diet, environmental, microbiome, that those are some of the things that have been posited in terms of this rise. And that, could you repeat the second question? Maybe make sure I get that.
Immunotherapy more effective for primary liver or metastatic, and why is that?
Yes, so that is a great question. I mentioned using neoadjuvant therapies. And so we know that some immunotherapies, when used in the neoadjuvant setting for certain diseases, can actually be more effective than they are in the metastatic setting. And that's likely because some of the suppressive populations that we see, and also intratumor heterogeneity, those increase over time. So there's more barriers that immunotherapy may have to clear to get effective anti-tumor response in a primary tumor versus a metastatic tumor. I don't know though if your question is about primary liver cancers versus liver mets, or more of just the general stage of the cancer.
It seems like the person is talking about general metastatic.
Yeah. So, I mean, the other thing I will just add about this, which is this is a challenge in the field, is that liver metastases, regardless of the tumor type they arise from, seem to be immunosuppressive themselves. So we know, for example, in patients with colorectal cancer, melanoma, when they have a metastatic lesion that's in the liver versus the lungs or the lymph node, that immunotherapy is not going to be as effective for those patients. And that is a big challenge that many are working on in the clinic and in the lab.
Great. Thank you, Les. Yeah.
Thank you so much for sharing. I'm Chris, I'm one of the categorical interns. I was curious in particular with these cell therapies, like CAR T cell therapies. I know they take an amount of time before you're able to give them. And for these patients that have quite high mortality, is that a barrier at all for treatment?
Yes, I think that's the simple answer. And some of the things that we put into this Athena protocol, Dr. Kelley was actually involved very early on, and then later looped me in with the sponsor to try to think about how do we get patients to this point. And so one of the things is identifying patients almost as soon as they're diagnosed and on first line therapy, to get them in to start pre-screening their tissue and get the ball rolling essentially before they've gotten through too many lines of therapy, and we might not be able to catch up with the cancer and get them onto a CAR T cell trial quickly enough. And then the other part of it is, at least at this point where these therapies are highly experimental, selecting for a more fit population, and eventually just with checkpoint inhibitors, we can maybe roll those out to a more real world population once we've done the initial safety and efficacy studies.
And one other thing, that actually, ironically, Bridget and I were just talking about a patient and how long we had to get her from her cell apheresis to infusion. And one of the protocol features that has been included is the allowance of a bridging therapy for a short half-life type drug, where we can give a sort of a temporizing treatment. And in this case, we have a patient where we're using the tyrosine kinase inhibitor lenvatinib that has just a couple day half-life. So we can start and stop it really quickly in a pragmatic way and hopefully keep things stable for a window.
How long does it take to get the CAR T already?
A month.
About a month,
Yeah.
Okay, great. Thank you both. This is a terrific and really interesting and very important thing.